A very good evening, everyone. Welcome to this webinar on effective implementation of genetics in obstetric practice. What are we missing? We thought of conducting this academic activity in this unprecedented lockdown period, as we all know that none of the CMEs are being conducted and everything is happening virtually at this point in time. Amidst this global pandemic of COVID-19, I would hope and pray that you and your ones are safe and healthy. And my thoughts also to all our colleagues, our paramedics, as well as our authorities who are striving day in and day out to contain this epidemic. And I hope that this gets contained soon and all things normalize very fast. These are some of my disclaimers. Some of the pictures within this may be a little disturbing, especially a few 3 or 4 autopsy pictures may be a little disturbing, so viewer discretion is advised in this regard. Now, essentially what I plan to cover is we'll discuss some basics aspects of genetics, like certain things about chromosomes and genes, the relation between the two and all these things, and some of the common case scenarios that we encounter in routine obstetric practice. And these would include certain uncomplicated low-risk pregnancies wherein we plan a proper genetic screening. Then we'll discuss a few things about recurrent pregnancy losses. In certain cases, the outcomes are not as expected, like there could be certain anomalies in the fetus, or there could be sudden intrauterine deaths or neonatal deaths. How to work up these cases is what we'll discuss through case-based scenarios. Then you will always get cases wherein the family comes with a history that there has been some member in the family, either the child or some of their relative, who's affected with a certain genetic condition, and they would want to know the risk of recurrence in the future pregnancies. So how do you approach these cases? And finally, how to plan antenatal testing in cases when there's some genetic issue in the family. Towards the end of this webinar, which would last, my talk would last about 45 minutes, and I can some of those immediately and in that context. Now, we are in an exciting time in the field of medical genetics. As you see in the picture, that lady is going with a gene chip to the medical store, and she would like to know as to what medications would be useful or would be beneficial for her clinical condition. The day is not far when all our genetic kundali can come into a small thing as a gene chip, because modern technology is now available at our doorsteps, and I'm sure all of you must be getting the laboratory representatives coming and telling you more about arrays and exomes and all these things. So all the clinicians, including obstetricians, must be aware of and must be updated with the current changes in this genetic scenario, which is really fast changing in our country. So what is important is what tests do we offer? So we have to order the correct investigation at the correct time and with a proper interpretation and reporting that is available from the lab. Along with this, because this is going to help us in counseling and planning for the prenatal investigations for the family. And all this has to be done within the ambit of the PCPNDT Act and knowing all the medico-legal implications that we all encounter in large numbers nowadays. So you have to be careful in these aspects as well. So a good basic knowledge of genetics will definitely help you in your practice as to how to approach a particular patient and when to refer the patient to a specialized genetic center. So as I say, this is always a teamwork wherein the obstetrician at the helm, because he is the first point contact with the patient, helm of the affairs, and he is duly supported by the clinical geneticist, by the fetal medicine expert, and a good laboratory. And this team effort is really going to take the fetus, is going to take care of the fetus, and as well as their parents and their families as well. So it's a good teamwork and team effort that really minimizes many medico-legal and other issues as well. So we are all aware of these so-called old generation tests. You've heard a lot about karyotype, you've heard a lot about FISH, you've heard a lot about PCRs. Now, these are so-called old generation tests, but we know that these are useful even in today's context as well. But now we are very fast moving towards a genomic era, wherein you have these next-gen sequencing or exome-based studies, microarrays or chromosome CGH arrays, and non-invasive prenatal testing, as we call it, NIPS or NIPT, And we are moving towards a pre-implantation genetic era wherein the testing of the embryo for genetic disorders before implantation is soon going to be very much possible. So in this scenario, we must know which test has to be done in which clinical scenario. So to understand that, let's go a little bit into genetic aspect. Now we all know that we have 46 chromosomes, a pair of chromosomes from 1 to 22, XX if it is a female, XY if it is a male. Now these chromosomes, so only do these chromosomes alone constitute our genetics? The answer is yes, but the answer is no also. Because if you look at the chromosome in this, as you can see in this diagram, you have the single chromosome, which is actually a long thread of DNA. Okay, so it's like a long thread which is coiled and supercoiled to form this compact structure called chromosome. So chromosome is nothing but a long thread of DNA which is wound around itself. So essentially, if the problem is at the chromosomal level, so you have some extra chromosome or a missing chromosome, you call that as a chromosomal disorder. Like for example, you have Down syndrome. Sometimes what happens is the chromosome is intact, but certain chromosomal segments may get deleted or duplicated. These are called as contiguous gene deletion syndromes, or which are typically detected on microarray. The issue sometimes can happen at the level of the rung of the ladder, as you can see with the pointer, wherein the bases like A, T, G, C, one of the base changes, and that point is what is known as a mutation per se. Now, essentially, if you're looking at 46 chromosomes alone, these 46 chromosomes contain about 25,000 known genes, which is only 1% of the entire genome. And this has about 3 billion base pairs. So you can imagine a single cell has these 46 chromosomes and these 25,000 known genes. So the issues can be at the level of the chromosome, or at the level of a contiguous gene segment, or at the level of the base pair. So going to the next slide, you can see that I give an analogy to a book in the bookshelf. Now, if you're looking at each of the book from outside, looking at it and keeping it back, you're looking at the chromosome. Suppose you're opening every chapter of that book and looking at the presence of that chapter or absence of that chapter, that is when you're looking at the microarray level. And when you're going to the page level and trying to read each and every letter by letter, each page letter by letter, that is when you're doing your sequencing. You can either do a single page when you're doing a Sanger sequencing, but if I'm reading about 200 or 5,000 pages at a time, that is when I'm doing exome or next-gen sequence-based testing. So with this background, what we'll do is we'll start with certain scenarios which are common in obstetrics, and I'll try to discuss it with case-based examples. Now, in cases of low-risk pregnancies, and if there are certain abnormal markers on biochemistry and on scans, I like this cartoon from the NHS very much because it summarizes in a single slide the various steps that the pregnant lady goes through from conception or preconception stage through the just up to the postpartum period. So if you look at this, I usually can discuss it in 4 points. So these 4 points are critical and must be remembered, and this must be considered for all pregnancies, irrespective of their age, their ethnicity, their background, etc. One is periconceptional multivitamins and folic acid. Second is screening for thalassemia and blood group. Third is screening for Down syndrome, common aneuploidies, and preeclampsia. You're going to do this by considering certain blood tests and USG scans. And finally, you screen for gross anomalies on the ultrasound scans. So the first point, that is periconceptual folic acid and multivitamin, they are very, very crucial, because if there is a deficiency of either of these, it can lead to issues such as neural tube defects. As you can see in the leftmost picture, of varying degrees. It can be a cleft lip, cleft palate, or a cleft lip and palate, and also cardiac diseases. We know that a depletion of folate and B12 alters the methylation status of various genes, and because of the altered protein function and the gene expression abnormalities, it leads to a neural tube defect. So we understand that this is one of the areas of birth defects which is largely preventable by a good periconceptional folic acid and multivitamin. It's not only folic acid, it should be folic acid with vitamin B12, because vitamin B12 deficiency is also known to cause these conditions. So what is the burden of these disorders? So you understand a lot of, you can see this is one of the slides from the CDC USA, which estimates that in 1 in about 5,000 babies may have an anencephaly, or in 1 in about 3,000 babies, could have a spina bifida without anencephaly. So you can see the incidence is so high. If you go and look at cleft lip, cleft palate, 1 in every 1,000 babies may be born with a cleft lip and cleft palate is what has been discussed in literature. And it has been proven that periconceptually, so at least about 3 months prior to planning the pregnancy, they start folic acid and vitamin B12. That is going to help them, that is going to help reduce the burden of these very treatable disorders. So after my first step, we go to the second stage, that is screening for thalassemia and sickle cell anemia. Now, these are the two conditions which are very common in our population, and we must remember that it is not ethnicity based. We know that certain communities, thalassemia is common, but even in certain other communities as well, we know Kachis, Lohanas, Sindhis, population, this is very common. But even in Maharashtra and in the surrounding regions, we get a lot of thalassemia, and so as a result of which it is necessary and to screen the couple for a thalassemia by HPLC at the first antenatal visit. So typically what is done, you plan an HPLC in either the wife alone or both, in both the husband and wife, and based on what their status is, we need to plan the further investigation. Now, typically what happens is patients come with a pregnancy and they get a thalassemia screening done. But since thalassemia gene, it's a beta globin, it's a single gene, it is pretty easy to finish the entire prenatal diagnosis even if the patient has come with a pregnancy. So at the first antenatal visit, if we have the thalassemia screening done, we are in a position to offer a good prenatal diagnosis on the CVS or sometimes even on the amniotic fluid sample. So typically we know that there are about few common mutations that account for 90 to 95% beta thalassemia in our population. So first step is carrier screening. Then we go ahead with identifying the mutations in the beta globin gene of the couple, and if there is a pregnancy, we offer a prenatal diagnosis for that. So thus the second point is thalassemia screening. The third aspect is we have to screen all patients for Down syndrome because it's the commonest genetic disorder and the incidence is as high as 1 in 700. We know that we all screen nowadays. We must be having, you used to do a cord TSH, or we do a newborn screening nowadays for congenital hypothyroidism. The incidence is 1 in 1,000. Incidence of Down syndrome is higher than that. It can occur to parents of any age, any socioeconomic status, and it's a genetic condition, but it's not an inherited condition. So absence of a family history, a young age, is no bar for a Down syndrome to occur in the family. So essentially, since it's not curable and it's not primary preventable, it is essential that we can offer a good screening for all ladies of any age group. So we have these guidelines from various OBGYN societies which suggest that all pregnant women, irrespective of age, should be screened for Down syndrome, and maternal age alone is a very, very poor minimum standard for prenatal screening. Now we'll understand why Down syndrome occurs. So if you look at this cartoon, you can see that both the husband and wife have 46 chromosomes. They're going to contribute only 23 each from either of them to give rise to a fetus with 46 chromosomes. But in the lower cartoon, you can see the female has contributed 24 instead of 23 in one of her gametes. The husband has contributed a normal number of gametes, and these lead to an extra chromosome which is causing Down syndrome. So you can see the parents are normal, but Down syndrome has occurred. So this is an accidental event, and as we know, accidents can occur to anybody at any point in time. So even a 19-year-old can have a baby with Down syndrome, and even a 40-year-old can have a normal baby without considering it. So screening is a must for every age group. Now we'll see Down syndrome. The commonest type of Down syndrome is trisomy 21, wherein you have an extra chromosome number 21, which is causing the effects. So how do you effectively screen for Down syndrome? We have various screening options. If you look at only the ultrasound, then we know the detection rate is about 70%. The best screening is obtained by a combined screening wherein you use a first trimester blood screen and the ultrasound, and that gives a detection rate of almost about 85%. So it is very ideal to consider the NT scan along with a double marker screening test in between 11 to 13.6 weeks to get good optimal outcomes and have a good screening result. You have other methods as well. There's an integrated screening when you can do a first trimester along with the second trimester, which slightly improves the detection rate to about 90%. So essentially, when we are screening, you have a few things. A first trimester maternal screen will have two components, a double marker, that is PAPI and beta HCG, when you combine with knuckle translucency. And the second trimester, you have the alpha fetoprotein, beta HCG, UV3, and inhibin A. So it's a quad marker test, as we call that. But always, as a gold standard, we would prefer to consider a combined screening which integrates double marker along with the NT scan. Now we must know what prenatal screening detects. Now, prenatal screening is not a test which we do for all the conditions. It is a screening for Down syndrome predominantly. So risk estimation for Down syndrome is what is obtained. If you're doing an AFP levels, you'll get estimate about the open neural tube defects. It gives you risks for trisomy 13, 18, triploides, Turner syndrome, etc. And there are very good markers available for adverse pregnancy outcomes like SGA, preeclampsia, preterm delivery, etc. But it is out of the scope of this current talk. So I have not included this particular things in my talk. So what do we look for? So essentially when we are reading, so we are all used to reading these prenatal screening reports. What we should be reading and looking at in these reports is what I'll discuss next. Now, whenever you get a value, you are getting some values in the form of nanogram per ml and something called MOM. It's called multiples of median. So over in this particular table, 33.45 nanogram per ml is considered to be 1 mom, which is the standard that should be obtained at that particular gestation. If the value of that is half, then it is 0.5 mom. If the value is double at that gestation, it is 2 mom. So mom is multiples of median as to how much fold that analyte is increased or decreased, that should happen, that should be there at that particular gestation. So it is the MOM value which is going to be very critical when we are reviewing these prenatal screening reports, and this I'll highlight with some of the further slides. So what you look at is the marker patterns. Now typically in neural tube defect you have an increased alpha fetoprotein while the UV3 beta HCG is normal. Trisomy 21 you have a low AFP, low UV3, low beta, increased beta HCG and a low PAPI. While if you look at trisomy 18, all the markers would be low. So essentially based on these marker patterns, the risk for a particular condition may be going in a high risk or a low risk zone. So now what we'll do is we'll discuss some of the cases, and based on those case scenarios, we'll take a call as to how to approach these particular cases. Now we have a 23-year-old primary gravida whose weight is 72 kilo. The NT scan seems to be normal at 12 weeks. So when the combined screening was done, what we find is the values that we are looking at, the MOM values, they are very close to 1. So which is relatively a good result. And if you look at the final result, you're saying it is a screen negative or a low risk result. So essentially the risk for Down syndrome is on the lower side. You cannot say that Down syndrome is ruled out in this case, essentially because we must know that this particular combined screening will pick up Down syndrome with about 80 to 90% accuracy, right? So we have to explain 15% cases may be missed despite having a low risk result on double marker. So this is how you interpret these results, and this is how a counseling takes place when you have a low risk analyte result. Now we'll go for the next case wherein a 35-year-old lady has a bad obstetric history. She comes with 3 first trimester miscarriages. No genetic workup has been done. And here you can see the marker trend. NT seems okay. The PAPI is low. It's only 0.26 and the beta HCG is almost threefold elevated. It's 2.9. And thus the risk for Down syndrome is 1 in 90. It's a screen positive result. So screen positive result doesn't always mean that the baby is affected with Down syndrome, and termination of pregnancy based on this result is not at all advisable. So it only suggests that this result is screen positive and you have to proceed with further investigation. So which are the options that are available for this? Now it's a high maternal age, there's a bad obstetric history, the risk is high, and there is an adverse marker trend. So you have 2 options. One is a non-invasive prenatal screening or an amniocentesis. This patient opted for an amniocentesis and unfortunately the fetus had Down syndrome. So here you can see there are 3 chromosome 21, and this is a FISH study when you can see 3 dots which indicate there are 3 chromosome 21s. FISH gives us a quick result in about 2 to 3 days time, while karyotype may take about 2 to 3 weeks because it requires culture. Now going further, we have a 21-year-old lady who's a priming. She has there's a 3rd degree consanguinity. The NT is raised. It's about 5 mm at about 11.5 weeks. So all these things have to be taken into consideration while interpreting the reports. And there is a mild scalp edema which is noted as well. Now you see the mom value of NT is almost 5 times that it should have been at that particular gestation. Also, the level of the other markers is also very low. And what you see is a screen positive result for all these three conditions. So typically it is because of the high NT and the low analyte values that this risk has come out to be a high risk case. Now in this case, typically there is no point in considering an NIPS because we know that NIPS is again a screening test. I'll come to that in a few slides from now. But a raised NT may be associated with aneuploidies, certain non-aneuploidy related conditions like a diaphragmatic hernia or a congenital heart disease or an omphalocele or certain skeletal dysplasia. The patient opted for considering termination of pregnancy in this case. But what we suggested that we store the DNA sample and we also consider a fetal autopsy. And as you can see, in this case, the fetal autopsy and the further testing suggested that the fetus had a genetic condition which is called MPS I or Hurler syndrome, which is a very high risk of recurrence in future pregnancies. So though the screening is for Down syndrome, it sometimes gives us an idea based on the markers or the sonography findings as to what other conditions it could be presenting with. Over here in this case, it's a 28-year-old primigravida. The NT is normal, but here you can see the NT mom is all right, the BAPE is good, but you see the beta HCG mom is almost 7.5. That is, the value is almost 7.5 times elevated than it should have been. Then the risk for Down syndrome naturally has come out to be high. We checked that beta HCG injections were not given in this patient. Also, an amniocentesis was done, the karyotype was normal, and serial follow-up scans were done for placental insufficiency. And later on, it was found that the patient had a really bulky placenta. So sometimes it does give clues of certain conditions, like a bulky placenta usually gives rise to high levels of beta HCG. So typically, looking at the marker pattern abnormalities, we can suspect certain conditions. Like for example, elevated AFP is associated with neural tube defect. I'm particularly worried about a low UE3 and a low PAPE, which sometimes signal conditions other than Down syndrome. Like for example, we have, in the next slide, we'll see how the low UE3 presented with a congenital adrenal hyperplasia. So now this 28-year-old lady, there's a previous intrauterine death. She has come at 34 weeks due to oligohydramnios. Now she has come, the NT scan was normal at 13.5 weeks. She did not do a double marker and a quadruple marker was considered. And anomaly scan at 19 weeks suggested an ecogenic bowel. So over here, if you look at the marker pattern or marker trend, you can see the UE3 levels are particularly on the lower side. So as I suggested in the previous slide, low levels of UE3 and low levels of PAPE may signal certain single gene abnormalities. So you have to look at these moms very, very carefully, and what you find here is the risk for Down syndrome was increased. So naturally, we considered an amniocentesis and a fetal karyotype was done, which was noted to be normal. So we discussed, a counseling was done and the pregnancy was continued. Unfortunately, later on, the baby had a preterm normal delivery, birth weight was normal, and at birth, the baby was found to have ambiguous genitalia, and it turned out to be a congenital adrenal hyperplasia. So in the karyotype, we looked at all the books and counted those which were normal. But when the congenital adrenal hyperplasia is a single gene condition which is occurring at the page level. So essentially, a CAH was picked up. We have to look at these marker trends very, very, very carefully. Now we have this 38-year-old lady has a precious pregnancy after history of infertility. 1, and her risk was in the intermediate risk zone, 1 in 380. So typically how to proceed in these cases, so it's called contingence. If the risk is less than 1 in 1000, you can stop screening. If the combined risk, including the NT scan along with the double marker, is between 1 in 100 to 1 in 1000, you can always provide them the option of a non-invasive screening, the NIPS, or an invasive karyotype, or in very, very rare scenarios, we do suggest integrated screening, including the quad markers. But typically, you have to give them all these three options, especially those patients who are in the intermediate risk category. And wherever the risk is more than 1 in 100, you have to consider an invasive testing for these patients ideally. So now we'll just move on to the NIPS. NIPS is typically, it's called non-invasive prenatal screening, and it looks or it picks up the cell-free fetal DNA which is circulating in the maternal blood. It can be detected anytime after 9 weeks of gestation, but the amount goes on declining as the gestation advances and the placenta goes on maturing. And what it looks at essentially, now we can look at the maternal DNA or cell-free DNA is constant. It has the chromosome 21 fraction, which is constant. If the fetus has a normal fraction, then it will show a normal fraction result. But if the fetal fraction is increased, then that indicates Down syndrome. So what is important is whenever you're looking at the fetal fraction, that and the ratio of the expected, which is expected for trisomy, will depend on the fetal fraction. So anything below 3.5 is not acceptable. Anything beyond that, you can interpret the results with a fairly good accuracy. So whenever we are talking about NIPS, it is still a screening tool. And when the fetal fraction is more than 4%, you can have a sensitivity of almost 99% in detecting Down syndrome pregnancies, but it is lower for the other trisomies as of now. So you can see for trisomy 18, it's about 97.4, and for trisomy 13, it is 87.5. So essentially, when we are talking about a continuum, it is NIPS is more towards a diagnostic test, but as yet, it is not a diagnostic test. So it is not replacing your amnios and CVS as of today, but it's still a screening tool, and any NIPS screen positive result should be confirmed with a definitive testing. The previous case, when we showed the risk was in an intermediate zone, the fetus was found to have Down syndrome. So you have to interpret these intermediate risks very, very carefully. So which are the ideal conditions or indications to consider an NIPS? So typically it can be an individual choice. It has a good detection rate, so any individual who is willing to consider the test can undergo that. Maternal age-related risk beyond 37, it's a good test to consider. A screen positive result, double marker or screening has been done, it suggests a screen positive result, but the mother is very anxious to undertake the amniocentesis procedure or CVS procedure, she can undergo this. Or any intermediate zone results, 1 in 100 to 1 in 1000 is when you can consider the NIPS. It is not a test of choice if there are any anomalies or major soft markers on ultrasound. So if there is a very high NT or there is an echogenic bowel, this is not the test to consider. If there's a multiple pregnancy or a vanished twin, the extra twin or the additional fetus is going to affect the results, and any known genetic abnormality which cannot be diagnosed by NIPS should not be considered. Like for example, thalassemias or Duchenne muscular dystrophy, these are single gene conditions. Remember that NIPS is a screening test for Down syndrome and chromosomal aneuploidies only. It cannot look at things which are at the page level. Again, this is what I highlight. So how does the result of a NIPS come out as? So this is a 27-year-old trimeme presented with a hypoplastic nasal bone, but the NT scan was otherwise normal. So you get a result at low risk or high risk. Okay, and you get it for common conditions and common sex chromosome aneuploidies, and always have a habit of looking at the fetal fraction which is obtained. Now we'll take this case wherein this second pregnancy, the previous child had a global developmental delay, was spastic dystoning. There was no genetic diagnosis, and she came with this pregnancy with the only indication of a hypoplastic nasal bone, nothing else. The intermediate risk was obtained on a double marker screen, 1 in 899. So an NIPS was considered for this particular patient, and that showed. So this is extended NIPS, which can also look at certain microdeletions. Though it is not a real standardized test, but it can screen for certain microdeletions. So wherein a large duplication was obtained at this 9P region, so we did a microarray on the amniotic fluid, and indeed the fetus did show a large duplication in this particular region, which was about 6.4 megabases. So this pregnancy was considered for termination, because we know that 9P duplication in literature, it is known that it causes intellectual impairment. So these are the cases wherein you typically can consider NIPS, but if NIPS suggests an abnormality, it should be confirmed with an invasive test. Going further, as we mentioned, we have finished the 3 points. Now the 4th point is ultrasound scans. So a good NT and first trimester scan at 12 weeks, anomaly scan at 19 weeks, a fetal echo at 23-24 weeks, Doppler studies when necessary, and serial growth scans is how the pregnancy should be spaced out as regards to the scans. So it is one important integral aspect of it's also called as genetic sonography. Now we go to the next set of indications in obstetrics wherein genetics plays a major role, and that's recurrent pregnancy losses. So recurrent pregnancy losses we define as 2 or 3 or more consecutive losses of proven pregnancies with post-implantation failure of conception. Now, looking at this, RPL is by itself a different topic altogether, and if time would permit, we will consider further webinars based on this particular topic as well. So, because it is one of the topics wherein we least know, so genetics comes a lot handy in these cases. So recurrent pregnancy losses, you call them as miscarriages or recurrent miscarriages when the loss of pregnancy is below 20 weeks or less than 500 grams. And if it is more than 20 weeks, you call it as an intrauterine death. So the incidence of RPL is quite high. It is 1 to 3% of all pregnancies may end up in a recurrent miscarriage. And what is the etiology? What are the causes for the recurrent miscarriages? So if you consider all the causes together, genetic factors account for 2 to 5% only, while anatomic, autoimmune, and other factors are essential. But if you consider, you split it as per the trimester, you can see almost about 50% of the first trimester miscarriages are genetic in nature. So essentially, when do we start? The question is, when do we start investigation? So it's preferably after a second loss is when you start the investigations, because nowadays the pregnancies are occurring late. There's a significant depletion in the ovarian reserve due to age and the other factors, and treatment options are available. So we should not be denying the diagnosis to the patient and treatment till 3 losses occur. So there are a lot many evidence-based guidelines which have also come up in this regard, and these are widely available on the internet. So there are a lot of evidence-based guidelines pertaining to RPL. Now, if we consider the abnormalities at the chromosomal level, if you look at it, majority of the cases are numerical or sporadic abnormalities, that there could be trisomies or monosomies, which are not viable pregnancies, and they end up in a miscarriage. But when we are dealing with recurrent pregnancy losses, 2, 3 or more, the problem is less likely to be a numerical abnormality, is more likely to be a structural abnormality. That is, as you can see here, there is a structural rearrangement of the chromosomes that is leading to the problems. So essentially, we must remember numerical abnormalities, that is trisomy, trisomy 16, trisomy 21, trisomy 22, these are sporadic abnormalities. And if you look at, so essentially you will pick this up in the POC samples. You study the products of conception, you find a sporadic abnormality or a numerical abnormality, we know that this is essentially a sporadic problem wherein the parents are going to be normal. But sometimes what we find in POC samples is there are deletions and the parents are showing an abnormal karyotype. That is when these conditions are going to be recurrent in nature. Now, going forward, essentially at the second pregnancy loss, you should try to obtain the products of conception, and ideally it should be collected by a dilatation and curettage, because if you consider DNE, that it typically leads to a lot of maternal cell contamination. So sample collection by dilatation DNC is what is suggested, and typically we ask them to collect in a sterile container with a medium or with a saline gentamicin mixture, and we will consider first line testing on the POC will be cytogenetic in nature. In just a bit, I'll come to which test we need to consider, but this is how we typically would collect the samples. You have a sterile container, you can add some gentamicin, you can pick up certain chorionic villi. If the fetus is a little grown, then you can collect some tissue samples, skin clips, etc., which can give us good quality samples as such. So which are the tests that we would plan to consider? So we can consider a karyotype or a FISH, but the problem is karyotype requires a culture. Now already the tissue is a non-viable tissue. So there are difficulties in culture and there is risk of bacterial contamination. So almost about 70 to 80% there's a culture failure rate, and there's a large issue pertaining to maternal cell contamination as well. While if you do only a FISH, it gives you only a limited information about 2 or 3 chromosomes only, and that too a numerical. Like here you can see there is a trisomy 21. Nothing, it doesn't mention whether it is, a particular chromosome is translocated or what type of trisomy it is. So essentially it gives very limited information as it checks. To our rescue here is a microarray. Because if you look at a karyotype versus microarray, a microarray gives about 15 to 20% more information than a karyotype alone. So if you're considering a POC sample, a products of conception sample, microarray gives a more detailed result. It can detect chromosomal imbalances which can lead to miscarriages. Very few aberrations, only balanced translocation can be missed on this, but all the other aberrations will be picked up over here. There's no need for culture. So the need for, typically the culture failure which occurs with a karyotype is obviated here. Maternal contamination, however, must be checked with each of the samples, and this can be done on stored DNA as well. So this is the advantage of of a microarray over a karyotype on the POC samples. Now, typically going forward, we'll take this case example wherein there were two pregnancies. The first pregnancy was terminated at 20 weeks. There was a major cardiac abnormality with a VSD, a DORV, a narrow pulmonary artery, etc. And in the Gravida 2, again, there was a similar recurrence. There was a large perimembranous VSD, left ventricular outlet obstruction, and polyhydramnios. Now, in the first case, no genetic testing was done, but in the second case, we considered a microarray on this fetus. And when a microarray was done, we found that there was a deletion on chromosome number 22. If we would have done a karyotype or only a fish, which would involve 13, 18, 21, this would have been missed. So this was pertaining to DiGeorge syndrome. And why was it recurrent? When we probed further, the parental testing was done, and the father showed a similar aberration on chromosome 22 and had a little bit of facial dysmorphism, intellectual disability, and a very mild asymptomatic type of a cardiac disease. So here what happens is the father is a carrier of this microdeletion, so the risk of further pregnancies jumps up to 50%. So in these cases, we can always offer a good pre-implantation genetic testing or a good prenatal diagnosis if the pregnancy progresses beyond about 16 weeks without a major cardiac issue. However, if product of conception testing is not possible for some reason and there have been recurrent pregnancy losses, in this case, a karyotype must be considered, because we must know that microarray cannot pick up balanced translocation. So if you cannot test the products of conception, then you have to proceed with the couple karyotyping, which will help in ruling out balanced translocation, which are the important cause of genetic causes of a recurrent miscarriage. Now, moving further, we'll come to certain unexpected outcomes and anomalies, like there could be anomalies or some intrauterine or neonatal deaths. Some of these pictures may be a little disturbing. So typically now this fetus has presented antenatally with a cleft lip and cleft palate. So the pregnancy was considered for termination, and we considered an autopsy. Now, what autopsy showed us? It showed us many other findings, like there was a significant, oligodactyly, there was a thumb aplasia, hypoplasia, and there was flexion contractures at the wrist, which were not picked up on the ultrasound scan. So based on the features of the face as well as the limbs, we could delineate that this is a case of Roberts syndrome, and then we could consider a specific genetic test of the ESCO gene mutation, and we could tell them that the recurrence risk in the future pregnancy is going to be high. So doing an autopsy gives at least about a 15 to 20% more information than what an ultrasound can tell us about. Then sometimes we do a visual autopsy. Visual autopsy is just take photographs of the fetus. Sometimes it may not be possible to evaluate the fetus in detail, because now in this case what has happened is they had a first loss, a similar preterm labor at 6 months with fetal anomalies, and they again came at 24 weeks with subdural hygroma, pleural effusion, and poor prognosis was explained to them. The fetus was delivered at 28 weeks. It was large. So it was not possible to consider a full autopsy for this patient. So we considered a visual autopsy, that is only take the photographs of the fetus and store the samples. So based on the photograph and when we did the genetic testing, could identify a MuSK gene mutation, and which leads to a condition called Pina-Choquer syndrome. Now this is again a genetic syndrome with very high risks of recurrence. Now a very interesting case, sudden neonatal deaths. Like this is a non-consanguineous family. The first baby was born well, 2.5 kilograms. It did not cry. Baby died on day of life 1. It was suspected to be a HIE-like case. The second baby again was delivered by C-section. Birth weight was good, and again developed seizures, poor feeding, altered sensorium, and again died at day of life 4. So the entire blame was coming on the obstetrician that it is some obstetric issue that is causing these recurrent HIEs. Now, this fortunately for the second baby, an MRI scan could be done. So this definitely is a food for thought, that why two babies who are well grown, born by C-section, would have a hypoxic inside. So essentially in this case, the DNA was preserved, and we could identify a mutation in the MTHFR gene which caused hyperhomocystinemia. So what was happening is, in the antenatal period, because of hyperhomocystinemia, there was antenatal thrombosis of the brain vessels, which was leading to the hypoxia in the antenatal period itself. So essentially what is important is, even if we cannot save the children, we can collect some samples available. So what we always advise, if it's an ongoing pregnancy with an IUD, we try to collect fetal samples as is possible. If possible, the best sample would be a blood sample collected in an EDTA container. And what do we do on this sample? So essentially, if the fetus is small in size and a detailed autopsy is possible, you go ahead with a fetal autopsy. A detailed autopsy is ideal, but if it is not possible, at least a visual autopsy based on the available photographs is going to help. Collection and storage of samples in all these cases is the key, because essentially you store the DNA, and on the stored DNA, it can either be a cord, it can be a cardiac blood, cord blood, cardiac blood, it can be a cord piece, it can be a skin clip, and this DNA can be stored and tested at a later date whenever the patient is in a mind state to consider the testing. So essentially, storage of sample is very, very critical in these cases. Now, there will be cases wherein previous children will be affected with certain genetic condition. And how do we approach these cases? Now, there is a child who is affected with a genetic condition and the patient comes to you. No prenatal diagnosis can be offered directly on the amniotic fluid sample. This is one thing that must be very, very clearly remembered, because we don't know where the aberration is. It's like as if I'm keeping 25,000 sheets of pages in front of you and asking you to search for something, which we really don't know. We know there are 25,000 known genes, and a genetic problem can be among these 25,000 pages, a single page, a single word, a single letter being changed. So typically, if you don't know what to search for, you cannot search for that problem. So prenatal diagnosis is not possible directly on the fetal sample. It is necessary to investigate the index child. Index child is the previous affected child or affected case. If the affected case is not available by chance, then you can test the parents as such by certain studies, which I'll come to case-based example later. And it must be attempted to consider testing or affected children and relatives before the couple plans a pregnancy, or at least at their first ANC visit at around 6 to 8 weeks, because if the patient comes late, it is very difficult to complete the investigations on time. So I'll give a case example now. This particular girl child now essentially has a normal birth history, attained head control well. She has multiple issues. Speech is not developed. She has autism. She has a lot of motor difficulties. She's unable to run, hop. So she has essentially a muscle problem as well as autism. Now we know there are almost about 200 to 250 genes which are muscle related genes, and more than 200 autism related genes. So it's as if I have to screen for all these 400 pages. So it will not be possible unless I know where the problem lies in the index case. Now, if you look at her investigation, a lot of investigations were carried out. We did a CPK, we did the MRI of brain, we did certain other genetic testing, we did a karyotype, we did a muscle biopsy, and ultimately we could find that this particular gene mutation is there, CHKB, which was causing the problem called megaconial congenital muscular dystrophy. So the risk of recurrence in the future pregnancies is going to be 25%, and now the prenatal diagnosis will be possible based on this result. Now, if you look at the amount of investigation that need to be considered in the index child, you will come to know as to how much time we will require for all these things. So naturally, if a patient comes with a pregnancy, it is very difficult, but at least if the patient is sent at the first visit, say around 6 to 8 weeks, still we may be in a position to complete the analysis. Now, sometimes what happens is we don't have a lot of information available. Now, unfortunately, this couple has lost 2 children, and both of them, there's something called verbal autopsy, wherein both had hypoglycemia, both had dark colored pigmentation of skin, and the review of previous records suggested that the cortisol levels were low, and these babies expired at 10 days and 12 days. So typically in this case, the children's sample were not available, but we could consider testing in both the parents, and simultaneous testing was considered, and we could identify a mutation in this gene in both the partners. And based on the clinical presentation, we could confirm that it is a condition called familial glucocorticoid deficiency, which is causing the problems in this family. So typically, even if the index case is not available, sometimes we are in a position to consider genetic testing for families. It's possible. Now, here typically what happens is the first pregnancy was a torch-like presentation. At 34 weeks, there's oligohydramnios, microcephaly, ventriculomegaly, intracranial calcification, the corpus was calcified, there was hepatosplenonephromegaly, cardiomegaly. And this baby naturally was delivered, and baby did not survive for long. But certain tests were done. The torch IgM was negative in the child and in the mother. So essentially the couple was counseled that this was looking like a torch infection, and they plan a next pregnancy. Unfortunately, again in the next pregnancy at 19 weeks itself, the baby was found to have oligohydramnios and an echogenic bowel. So naturally now, since this has recurred, so initially the suspicion was like a torch. But now when there was a recurrence, naturally we have to think otherwise. So we stored the DNA sample of this fetus, and we did the further testing. And we know that the causes of the calcifications and all is significant, but we could identify a genetic cause in one of the genes called TREX gene, and that is a condition called Aicardi-Goutieres syndrome, which is also called pseudotoxoplasmosis or pseudo-TORCH syndrome. So now here the risk is going to be 25% in their future pregnancies. So we have to be aware of all these conditions, like as I discussed previously, an HI mimic, or this is like an infection mimic, which we have to consider the genetic causes in. Now, sometimes patients will come to you with the reports, and we have to really take it at actual, whether it is, whatever the condition the patient has come up with. Being obstetricians, typically knowing the pediatric aspect of the report is going to be difficult. But we have this case wherein the patient presented with 2 consecutive pregnancies with non-visualization or agenesis of corpus callosum. Some genetic tests were considered, and what it showed was this particular gene mutation was suggested. A CDON gene variation was presented. Now, based on our phenotype review is we are going to match the gene presentation as well as the presentation in the child. It was not matching. So we mentioned that this was not likely to be causative of that particular condition, and any prenatal diagnosis on this particular gene mutation, if it was offered, it would have been catastrophic. So what we did is we just rechecked that data once, and we found the actual variant was in another gene altogether. So sometimes it is good to reanalyze this data. So essentially, even if the patient comes with a report, it is necessary to verify whether that same condition is really causative of the problem or not. So typically, just putting it in a single slide, when is the best time that the patient comes for a genetic evaluation? It is before conception. It's a green signal. But at least if the patient comes at the first antenatal visit, around 6 to 7 weeks, still we have some time in hand, about 6 to 8 weeks, to consider testing in the index case or the family. But if the patient comes at around 11 or 12 weeks, just directly for a CVS sample for an undiagnosed genetic condition, it's almost like a red signal. You cannot offer anything at that stage because the deadline for MTP as of now at least stands at 20 weeks. So the best period to consider this is preconception. Now, we do get cases, once in a while wherein they came with a pregnancy of 12 weeks and the MT was high in this case. There was a positive family history. Now, this lady's older sibling had spasticity, that is contractures, with seizures and cardiac issues. Now, this history was not considered to be significant, and the patient was the pregnancy was considered, and this definitely showed a high MT. Now, what I asked for is one of the pictures of that older child. So when I reviewed that picture, which was really hung on the as a photograph, so that was definitely looking dysmorphic. So I suggested that this could well be an X-linked condition. So we considered testing in the parents and simultaneously, and what we observed in the mother was a variant in the ATRX gene, which was causative of a condition called X-linked mental retardation and hypotonic fetus syndrome. The fetus did show an abnormal skull shape, an absent nasal bone, polyhydramnios, and had a suspected cardiac defect. So there was a recurrence of this condition, the occurrence of this condition in this current pregnancy. So essentially, critically reviewing the records or the previous history is going to be very, very important. Now, moving to my last few slides, how to plan a prenatal testing. So typically, we must differentiate what is a procedure and what is a test. When we are taking a blood sample by venipuncture, it's a procedure. When I'm doing a hemoglobin or thyroid, that's a test. So similarly, a CV biopsy or an amniocentesis is a procedure. When I'm doing a karyotype or a FISH or a Sanger sequencing, that is a test. So which are the procedures which are typically considered? So an early procedure is CVS, which really gives good quality sample. Amniocentesis is done at around 16 weeks. We rarely do chordocentesis nowadays. It's done for certain hematological conditions only. And what tests should be considered on the fetal sample? And that should be really guided by the history or the problem. Now, suppose there's a screening, which is a high risk, or there's an elderly pregnancy or a child with congenital anomalies, you may consider you suspect a chromosomal abnormality, and you'll consider a karyotype or a FISH or a microarray. But a pregnant woman has a child with a diagnosed condition like DMD. Then you have to consider testing for DMD or thalassemia or whichever other condition by that specific study. So the prenatal testing is typically guided by what the index case is affected with. What you can consider empirically is a microarray. Now, typically here what has happened is fetus was 12 weeks gestation, MT was 4 mm. The karyotype was noted to be normal and they came with a normal karyotype report. So while counseling, I gave them the option that can go a little deeper and consider a microarray. As you know, microarray gives about 15 to 20% more information than a baseline karyotype. And when we did the microarray, there was a large deletion on 1p36 region, which could have led to significant intellectual impairment in the fetus. So this was missed on a karyotype, because we know that there's a limitation of the karyotype. So in a pregnancy, you can always give them the options available. The patient can choose and pick whichever test he or she would, the couple would want to consider. So my final slide, take-home message would be: first, in low-risk cases, the 4 points, that is periconceptual folic acid, thalassemia screen, Down syndrome screen, and proper scanning. An abnormal scan or marker pattern should prompt extensive, mostly invasive testing. Products of conception, microarray is the ideal test to consider. For families with a bad obstetric history, so when there have been certain deaths or children or family members with disability, definitive testing should be offered early. So timely referral to a genetic center always helps in proper planning of the pregnancy further on, and no family ideally should be left out without an attempt to diagnosis in the era of genomics, because as this genomics progress, there are a lot of medical legal issues which are also likely to come up. So it's always better to be safe than be sorry. So you give them all the options, let the patient choose whatever they would want to consider based on the options available. So I thank you all for your patient listening to this webinar. I'll be happy to take questions. There are some questions which have already come up, so just let me go through those. Okay. I have a question wherein it is, okay. So I'll take a few questions now. When clinical exome sequencing is suggested, typically, a good question. Now, as I mentioned, now whenever no empiric testing should be offered on the fetus directly. So typically, if there is some family history of intellectual disability, a previous child affected with a genetic condition, or some family member affected with a genetic condition, I would prefer to consider testing in that member first. And whatever finding we have, then we're going to check that specific finding by Sanger in the fetus. But in some of the cases, you may not have the index case available. In this case, a trio sequencing, that is, you consider both parents along with the fetus, that is acceptable, because we need to have some baseline to really compare the genome. So essentially, doing a direct fetal exome is never advisable. Then there's another pregnancy, what sample is collected? What sample do we take for a karyotype? It is a EDTA blood sample that we typically would take. Heparin blood sample that we usually would take. If both parents are trait positive for thalassemia, hundreds of mutations are detected now possible associated. What panel should be performed for carrier or expanded carrier screening? How is the outcome in allelic heterozygous? So now in this case of the both parents are trait positive for thalassemia. So we know thalassemia, there's a single gene. So we did not consider any big panels here. We just consider beta globin gene common mutations followed by gene sequencing that will pick up almost 100% cases for thalassemia. If your further question really pertains to an expanded carrier screening, now if there's a consanguineous family which is really concerned as to what possible conditions they could be, what possible abnormal genes they could be carrying. So in these cases, typically we can always consider a coupled carrier screening. So wherein you consider exomes of both the parents and compare them. Whatever abnormal genes are present in both of them, we would plan to consider prenatal for that particular testing. Can an abortus be studied genetically is a question. Definitely it can be considered. So depending on the gestation, we can consider it for autopsy. And as I suggested, if there are major anomalies, you can always consider the products of conception for further testing, preferably by microarrays in today's era. Okay. So in every amnio or CVS, we should go for microarray is one of the questions, very interesting one. You can always offer the option, because typically, as I told you, over and above a karyotype, a microarray gives at least about 15 to 20% more information. So if the patient, in the resource available situations, I would always prefer a microarray to be considered in these patients, because naturally patients would want to know more about these conditions, because again, all these microdeletions are de novo conditions. They are not inherited conditions per se. When the genes are, or chromosomes are being transferred from one generation to the next, it is at that point that these microdeletions occur. So just like Down syndrome, these microdeletions are mostly sporadic conditions. So to pick up these conditions, you can always offer the option of a microarray always. Yeah. There's another question. If there's an isolated ARSA, is an invasive testing indicated? As we know, the ARSA is a significant soft marker for chromosomal aneuploidies, so an invasive testing ideally must be considered in cases with ARSA. How we can explain the patient to go for microarrays? Typically, as I told you, you can always tell them there's a karyotype, there's an array. So the difference, microarray is going to give you more information, about 15-20% more information than a karyotype. Or giving a simple example of the books on the bookshelf. A karyotype is just looking at all the books and looking at it from outside and keeping it back. While when we are doing microarray, we're looking at every chapter of every book. So it's going much, much deeper. Then there is in some cases we do a trio whole exome directly in the family. Sorry, there are too many questions popping in. Why do we do so? When to decide clinical exome and when to decide whole exome? Right. So now typically when we are talking about whole exome screens for about 25,000 known genes, while a clinical exome, it screens for lesser number of genes, say about 5,000 to 8,000 depending on the panel. So typically when we are screening a large number of genes for obscure conditions, so say for example I'm suspecting a very specific genetic condition, I'll prefer a smaller panel as such or a clinical exome. But if a condition is like epilepsy or an obscure mental intellectual impairment, in those cases sometimes your clinical exome may not give us answers. So in that case a whole exome is always better. In first baby has autism, how to consider prenatal screening of parents? Now typically what is important is autism. In about 20 to 25% cases, we do find a genetic cause for autism. So in these cases, typically what we would advise are testing of the index child first. That is, as a rule, whenever any affected child or affected relative should be tested first. So we'll test the child who has autism for first a microarray, and if that is negative, we can again give them the option of going deeper at the gene level. In about 20 to 25% cases only you're going to find a specific abnormality. All the rest, if it is normal, they can go with a specific risk of about 1 to 3% if it is a male child and about 3 to 5% if it's a previous female child. If fish is normal, should karyotype be done in case with high risk screening report and no other indications? It's up to the patient. Usually we'll give them the advice to consider a karyotype. Any which way they are considering a fish, so might as well add on the karyotype to at least have a good look at all the chromosomes at least. In case of a structural abnormality fetus, and if you want to take the sample from the fetus, which portion is best to take for sampling, or from placenta? A cord piece is good enough. You can take a skin clip, from the underarms, or you can take a small tissue of the great toe. Occasionally, you can also take the fetal villus portion of the placenta can also be a good sample for testing. Okay. Then there is a question called VUS. It's pertaining to really hardcore genetics, a variant of uncertain significance in the parent, so which is more often the case than not. You're going to get a variant of uncertain significance on clinical exome or whole exome. And how do you proceed further? There's another very important step which I didn't cover here because the limitations of time, is something called reverse phenotyping that we do. Reverse phenotyping is we have the genetic abnormality, we have the child or the reports of the child. It can be MRIs, it can be sonograms, etc. And we compare these reports and try to find out how much the phenotype is matching. So if the reverse phenotyping and segregation studies does confirm that yes, this is indeed a gene which is significant, then that VUS can be considered for a prenatal diagnosis. But in one of the other cases which I suggested, the CDON gene, it was a VOUS again, but which was not at all fitting with the phenotype. So we ignored that VOUS. But in that case, always a search should go on to really find out the abnormal in microarray, which test is advisable, low resolution or high resolution? You can always consider the issue will be the cost. So essentially, if the patient is affording, always a high resolution microarray is better because it is going to go at the subchapter level and it really goes much, much deeper in that case. What should be done if a couple has had previous 2 pregnancies with spina bifida? A very interesting question. So usually in this case, we have to think of certain single gene conditions as well. So we have to go much deeper into the history. We have to look at the family history. We have to, look at the consanguinity in the family. Always it's good to check if the patient really has had a periconceptional folic acid and multivitamins or not. Sometimes, the patient is not if it is, sometimes what will happen that even though the patient has had a spina bifida, they will not consider any kind of preconceptional testing or preconceptional supplementation. They'll come with a pregnancy with a recurrence. So all these things or aspects have to be really looked into in this case. So I think there are many questions which are coming up perhaps, but what we will plan to do is I will answer all these questions individually, and perhaps we have all your email IDs. I'll be happy to take all these questions and answer all your questions at a personal level. Perhaps I'll send you an email and answer those questions. You can always feel free to get in touch with us in case you have further queries or questions. So I hope you have found this particular webinar interesting. And I would also request you, in case you have certain other burning topics that you would like to have webinars on, you can always post it on this question link, and we will try to include these webinars in the coming days as well. So I thank you all, and again, best wishes to you, and you will definitely would have benefited from this, I believe. Thank you so much.